Thank you, Chewe, and good morning, everybody. I'd like to thank the organizers to give us the opportunity one more time to bring you some updated information on what we do at the agency. So I'll try to focus on what we have done over the past year and where we intend to go. I'll briefly review what I call the INRS prevention activities, which is slightly broader maybe than the topic of this workshop, and I'll highlight then some specific features on the 4 trials that we conduct at the moment and that have relevance to this issue. Basically, the alphabet of HIV prevention at the French agency goes from circumcision, counseling and testing, harm reduction, pre-exposure prophylaxis, prevention of mother-to-child transmission, use of antiretroviral treatment for care and for prevention, and vaccine. And I've just decided today to highlight 3 of them as new features have been developed over the past year. First of all, medical male circumcision. You may remember that the project that was conducted by French and South African investigators in South Africa was the first ever published randomized clinical trial demonstrating the efficacy of male circumcision. After that, a pilot program was rolled out in the same community of South Africa and showed extremely good program indicators. But the important conclusions of last year were released in PLOS Medicine at the end of the year. This is the first, to my knowledge, program showing HIV reduction at population level following the rollout of a male circumcision program. And in addition, at CROI last month, the confirmed benefits for women as well were also demonstrated by the same team. If I'm emphasizing a little bit the medical male circumcision here, this is because it's obvious that now it has to be part of any of the prevention global package that we are talking about in heavily affected populations. Second, I'd like to spend a few minutes on PrEP. This very interesting review by Chris Beyer just recently published appeals for much more vigorous prevention efforts, including the adaptation of expanded use of PrEP, if we want to reduce new infections among gay, bisexual, and other MSM. And clearly, PrEP in France and Canada with INRS IPERGAY goes into this direction. So the PI is Jean-Michel Molina. And the issue is as follows. There is relatively insufficient information on high-risk gay populations in Europe and other high-income countries with regard to the use of PrEP and the effectiveness of PrEP. There are issues of adherence that have been extremely well outlined by the previous trials, so we need to have more friendly regimens for long-term use of PrEP. And in addition, cost effectiveness and the risk of sexual disinhibition need to be documented. So IPERGAY is a randomized trial, placebo randomized trial. We're looking at the effectiveness of on-demand PrEP in a population of high-risk MSM, and it randomizes them to either receiving the full prevention services that are listed at the bottom of the slide, plus TDF-FTC before and after sex, and otherwise a placebo comparison. The incidence in this population is believed to be very high, and the expectation is to have an efficacy of about 50% demonstrated in this 2,000 population sample. The timelines are as follows. The study was launched only after the results of all the previous PrEP trials had been released. It's currently in its pilot phase in France and in Canada to ensure feasibility, and it is still looking for additional funding to move to the larger phase, although there is good promises for private-public partnership. Randomization has been already started quite a while ago, and extension in a larger scale to other European countries has even been considered. Let me move to the when to start issue. It may look also peripheral to our topic, but it's not at all. There was last year a plea in the New England Journal of Medicine for when to start studies in Africa. In fact, the agency had largely anticipated on that because we have a trial called Temprano, and the two PIs are listed here on this slide. One of them is in my team in Bordeaux, and this trial takes place in Côte d'Ivoire, West Africa. The assumption is that the when to start issue is really context driven. We know that there is a very large international SART trial that has only a small stratum in Africa, mostly in South Africa. We believe that in the rest of South Africa, of sub-Saharan Africa, tuberculosis and tuberculosis-related death will represent a significant proportion of severe morbidity and mortality, even at high CD4 counts. And we also believed in designing this trial that 6 months IPT and ART could enhance each other efficacy. So based on these assumptions, we designed a trial to assess the benefits and risks of starting ART and or IPT with adults up to 800 CD4 count and who otherwise had no criteria to start ART immediately. And these trials, which is a randomized 2x2 factorial superiority trial, is conducted in 9 clinics in Abidjan, Côte d'Ivoire. So you can see here on the slides the 4 arms with either no TB drug but ART when starting WHO criteria, either INH 6 months and ART normally, or immediate ART and or immediate ART plus INH prophylaxis. The length of follow-up is expected to be 30 months, and the outcomes are, I would say, hard outcomes, either death or severe HIV morbidity. In addition to these main outcomes of the study, there was a big decision to have social and behavioral aspects to this trial and to study within the trial or other outcomes at months 12 and 24, such as sexual and preventive behaviors, disclosure of HIV serostatus, unions, construction and breakdown, and professional social integration and discrimination. The good news is that this first piece of the study, which doesn't require to know the comparison between early treatment and not early treatment, has been very recently published about 2 months ago, and the conclusions with regard to sexual behaviors and the HIV transmission risk are extremely promising because the protective effect of early ART that has been estimated in this study nested within the trial is at about 90%, so it looks very similar to the HPTN 052 study conclusions. What are the Temprano main timelines? First randomization occurred a long time ago, March 2008. Completion of enrollment was July 2012. The trial will be fully completed by December of this year. There are a few meetings, important meetings in the coming weeks, but otherwise, as I said, the trial will be closed at the end of this year, fully closed at the end of this year. Finally, moving to the real issue of treatment as prevention, Margaret McNary and Wafa El-Saad basically this week published in CID a review on the issue, an opinion piece, I would say, but concluding that there is a need for evidence-based implementation science studies with the issue of effectiveness of ART for prevention. They did not really do what I would call a systematic review of the ongoing projects. In fact, this has been done by UNAIDS and will be reported tomorrow. So I am afraid they missed the INRS study in their discussion, and so I'll basically report to you what we do at INRS. This is the TASP trial. The TASP trial has a nickname in Zulu because it's conducted in South Africa. And I had reported last year already the design, but I will expand a little bit. That's a cluster randomized community-based trial. It's conducted in rural KwaZulu-Natal in South Africa, and we are 3 PIs to look at this project. The Schlabissa sub-district in KwaZulu-Natal, this black crescent at the top of the slide, is the area where the trial is implemented. It's a Zulu-speaking population, and the prevalence, as you see, is extraordinarily high. It has been high for a long time already, and the incidence and the transmission in this community is, of course, very high, and there is room for changes as we implement TASP. So the objective, very similar to the pop-out trial that was presented previously, is to really directly estimate the effect of a universal test and treat approach at the community level. What we mean by universal test and treat here is to initiate ART immediately after the diagnosis of infection, irrespective of CD4 count, and thus in people not yet eligible for ART. And the measurement of the outcome is really the incidence of HIV infection in the general population in the same setting. We have constructed this trial to be performed in two phases. The first phases that ended, in fact, a few weeks ago, was really to address the issue of feasibility and acceptability of this treatment as prevention approach that not too many people know how to do in the field. We started in March 2012 with 4 clusters, so 2 randomized to the intervention and 2 to the controls. And we added, hopefully, additional 6 clusters, 2 times 3, in January 2013, because we had more funding available. So we just finished this first phase, and we will move by this month, in fact, to roll out extensively the intervention at a larger level, which will allow us in about 2 years from now to evaluate the effectiveness in terms of reduction of HIV incidence. And this has made possible, again, because of a very powerful public-private partnership with the Bill and Melinda Gates Foundation together with NRS. Just to go a little bit more into the details, so the design of the intervention has 2 components. The first component applies everywhere. That's the full prevention and HIV testing strategy that is in place in South Africa, including male medical circumcision. But on the top of that, we implement a systematic and regular proposal of home-based HIV testing, roughly on a 6-month basis, going door to door in this community, and you have at the bottom of the slide the comprehensive set of preventive services that are provided anyway. And then the component 2 is this different in the cluster, control clusters and the intervention clusters. In the control clusters, we rely on the national guidelines on offering ART in South Africa, whereas in the intervention arm, we offer a universal and immediate ART initiation as soon as the testing has been performed and the announcement of a positive test has been done. This is how the trial clinics look like in this community. Either people go to the TASP clinic, which is on the top of the slide, or to the Department of Health clinic. Look relatively similar in their format. Simply, we have added more clinics to be closer to the people and to minimize their time spent to have services, and we can link the data in the two systems. So we have, of course, registered this trial and published the protocol in the journal called Trials, and it's an open access journal, so I will encourage you to read it if you want the details of the protocol. And as I said, the timelines were as follows. We finished at the early 2014 the first 4 + 6 = 10 clusters. We will now continue their follow-up and expand to 12 more clusters starting this month in April, and we should be able to report on feasibility and acceptability on the first phase in the coming months. So I'm afraid for Julio and the organizers of the committee that I did not a lot of very important new information in terms of findings of the trial on test and treat. The only thing I could do is change the logo of the agency that has been new since January 2014. But I think you should remain interested and follow what will happen in the coming months, because I think both on Temprano and on TASP we should, I hope, have some interesting findings to share. Thank you very much.